Okay, I'm happy to be here this morning talking to you. This is a very brief presentation. It's an informational presentation on equipment. It's really not dealing with, I'm not dealing with any scientific outcomes or anything along those lines. That's not the purpose of this presentation. I practice in Miami, Florida, as many of you know. I've been doing temporomandibular joint arthroscopy since 1986. So it's many years down the road of developing and working on this technique with my colleagues. Part of the frustration and the original thought process behind instrument development and doing procedures for temporomandibular joint arthroscopy, and always that has been my mantra and should be yours, is that we need to have enough equipment in our operating room to take care of our patients. Without that, and I've always been neurotic about that, having enough equipment so that we could complete our procedures throughout the course of my career. We've had some ups and downs in that particular arena, sustaining equipment for our operating rooms. I'm very comfortable now to say that certainly through the duration of my career, and hopefully through the careers of the young people in the audience, that you will no longer have those types of frustrations, but in fact have a set of equipment that's available to you that you can complete all levels of arthroscopy, both from a standpoint of hand instrumentation and arthroscopes, and you can count on the equipment being there for you so that when you're ready to do your procedures and you can perform your procedures appropriately and correctly and safely for your patients. Go ahead and advance the slide for me, please. It's not advancing. This is a concept, though, what we're talking about now. This is not just a procedure. I'd like to introduce to you a concept and a system to safely, and effectively perform minimally invasive procedures in a small joint. This is an arthroscopic view of a temporomandibular joint. In a case, obviously, that the joint's not very clean. We have some chondromalacia and some synovial redundancy, and this type of a case is a good candidate for arthroscopy, for advanced arthroscopy. Sometimes not necessary to do advanced arthroscopy, but certainly have the capabilities to clean that joint with the appropriate arthroscopic instrumentation. Advance, please. I would suggest to you that part of this concept, though, and it's pretty, those of you that know me know that I'm very, very rigid about some of the things that I think about, and I guess I'm just old-fashioned, but I do believe that things should be performed the same way all the time in order to accomplish a good goal. I know that there's journalistic freedom, and I know that there's the art and science of surgery that we do, and I appreciate that. But this concept doesn't really leave a lot of wiggle room. Okay, I would suggest to you that you pay attention to the details, and I'm not going to go into absolute details, but the details of joint puncture, the details of both punctures, and the details of the operation completely. And if you pay attention to those details, I can tell you that your outcomes will be good. If you vary from those details, I can tell you that you're going to potentially have problems. So I've been doing this for, like I said, a long time, so I've lived with some of the problems, but I think we have something now to offer that you can have very predictable results and you can perform safe surgery for the patient. With that being said, this is my hospital, Baptist Hospital in Miami. I would strongly encourage you to have the venue of your operation in the operating room while the patient's under general anesthesia. And you also should keep them overnight if you can, so you can observe them the next day. Of course, I know that there'll be pushback on that. That's okay. Your patient, particularly when you're starting to do arthroscopy, they should be asleep. And it will make you comfortable, and it'll make the patient comfortable. So when these procedures are done, I would strongly recommend that you do them in a hospital and you do them under general anesthesia. I would also suggest to you, every economic situation is different, but the onus of the economics in this type of a situation should be on your hospital. And they should be the ones that are purchasing the equipment, and you're performing the procedure. In the United States, trying to perform arthroscopy in an insurance world as an outpatient is really not productive. Okay, we have one code that we bill for. Everything's bundled into that code, and it's not really a very productive situation for anyone concerned. So I would suggest to you that when you go back home, if you are a passionate arthroscopist, that you set your situation up so that you can do your operation in your hospital, supported by your hospital, and you keep your patient overnight in the hospital so that you can see them the next day, and that you can medicate them accordingly in the hospital accordingly, because some procedures will be extended. So if you're into an operation and you're just looking, and then all of a sudden you want to do more, when the patient's in the hospital and you have the equipment beside you, that you can extend your operation without problem, that's an ideal situation, and that's what we're trying to create here. Next slide, please. The arthroscope that we have developed is not available for touching at this point in time. We're about 2 months away from having this arthroscope available. I have a lot of arthroscopic experience in developing equipment. I'm very proud of this particular arthroscope. This is developed by German colleagues, and we specifically sat with them for several days in order to develop this, so it's perfect for the temporomandibular joint. Arthroscopes have certain characteristics that are important when you scope a joint. This arthroscope is a 1.9 arthroscope. The outer diameter of the cannula is going to be about 2.1. The scope itself is 1.9, and you'll have some room inside the scope for irrigation to come down. The basic parts of the arthroscope, you have the needle of the scope right here. It'll be 50 millimeters. It's long enough for you to get into the joint and to access all parts of the joint without problem. The focal length of it will be from 0 to an infinity. So if you're at the lateral aspect of the joint and you want to see the posterior lateral, it will not go out of phase. You'll be able to see that aspect of it. Remember, our joint is only 22 millimeters by 22 millimeters. It has an extension here where you put your irrigation in. Your light cord hooks here. It's a 2-millimeter light cord. It has an angulation of greater than 45 degrees, so it doesn't hit against the head when you're rotating it. And this is the optics that you're looking at. This arthroscope right here is a 30-degree arthroscope that has this type of field of view. And it's important to use a 30-degree arthroscope. A 0-degree arthroscope will not permit you to do advanced arthroscopy well. You have to have a 30 degrees so you extend your peripheral vision and so that you can do double puncture arthroscopy and really execute the procedures correctly. Wide-angle scopes, 0-degree scopes, I do not believe will provide you with the type of advanced arthroscopic experiences that you need for your patients. This scope has an eyepiece at the end of it right here. Has an eyepiece right here that's going to couple. Next slide, please. Arthroscopes also, if you have a 30-degree scope, it gives you the ability to extend your peripheral vision. So a scope has the capabilities to rotate. I'm not sure what's happening with this thing. Scope has the abilities to rotate, so you can see in this situation that the angle of view of 30 degrees comes opposite of the light cord. So if you want to look at 9 o'clock, your light cord is opposite. If you want to rotate your scope to look at 12 o'clock, 1 o'clock, 3 o'clock, you can look at the whole joint. And it's important to be able to look at the whole joint because when you're triangulating, you need to pick up the instrument coming from the anterior component. So this is an important part of the design of an arthroscope. Next slide, please. There's 3 types of arthroscopic levels of surgery that you can deliver. Most of us do level 1 arthroscopy. We do single puncture technique, and then we lavage the joint. This is an example of level 1 arthroscopy. What can you do with level 1 arthroscopy? You can do diagnosis, you can do arthrocentesis, and I strongly encourage you to do your arthrocentesis under arthroscopic control rather than just 2 needles. There's a lot that you can contribute to your patient care if you're looking at the joint. And then you can also deposit selectively medications in the joint under arthroscopic control. And this depositing of medications, I think, is the future of our surgery. Next slide, please. When you're doing your arthroscopy, your single puncture arthroscopy, or double puncture for that matter, you have to use the fossa portal. The scope needs to be inserted cleanly into the fossa portal. This is a part of the procedure that can't be underestimated. You have to take your time. It has to be placed perfectly and consistently. And if you do it the way you're supposed to do it, it should be safe and effective. You shouldn't have complications of ear. You shouldn't have complications of facial nerve if you place your instruments in correctly into the fossa. Next slide, please. So in placing the fossa portal, you enter the joint, you touch, we know this, it's just a slight review. You touch the glenoid fossa periosteum, scrape down, and then enter your scope into the joint in that manner so that it's entered perfectly into the joint, over the synovium, in the joint, without scuffing the joint as you move forward with the procedure. And it's placed in such a way that you can negotiate the entire joint well and see the entire joint and set yourself up for additional procedures as you go on. Next slide, please. This is the scope itself. You see that the scope will introduce into the arthroscopic cannula right here. It's a very easy attachment. Once you put the scope in, you just push down on this button, it locks in. There's none of this twisting, there's no moving things around. It simply inserts into the cannula, fits very well, and you're ready to go. Having taught many people how to do arthroscopy and myself struggling with attachments, we feel this is very user-friendly, very ergonomic, and I think you'll be satisfied with the way the scope inserts. Next slide, please. This is just an example of level 1 arthroscopy then. This patient's asleep in the operating room. The scope is in the fossa portal. The irrigation needle goes anterior to it. It's easily placed, and then you go ahead and do your level 1 arthroscopy. And the first part of level 1 arthroscopy is the arthrocentesis of the joint. So before you even start looking around, once you're established with your irrigating needle, you know you're in the joint correctly, you need to go ahead and run your arthrocentesis through, don't chase your needle, and then go about, now you're finished with that component, you've evacuated cytokines, and you're ready to go with the second part of the procedure, which is the lavaging of the joint, the diagnostic component. Next slide, please. Next, please. Okay, so this is just an example of 2 additional motions of the scope. The scope, I already showed you the rotation. The other examples are the pistoning of the scope, where it goes back and forth along the same vector plane, and then the swiveling of the scope. So you have 3 scope motions: piston, swivel, and rotating. And the fact that you have a scope that allows you to go in all directions will permit you to cover the whole joint. Next slide, please. Back. Okay, so now you've done your diagnostic arthroscopy, your level 1 arthroscopy. You're ready to move forward into more advanced arthroscopy. You need to make a second puncture. The second puncture is placed just like this. It's the vector measuring system where your scope is in the joint. You get yourself to the anterior lateral corner. You measure out the depth of penetration of the scope itself, and then you place your second cannula. This is this is not for me to teach you exactly how to do this, but you can absolutely place your second cannula exactly where you want to place it. Not just guess, you can put it exactly where you want to place it, and it's important to do so. Otherwise, again, you're sort of stymied as far as how much you can move forward and backwards in the joint itself. Next slide, please. So now we have level 2 arthroscopy. So you now have a second puncture in the joint. And with level 2 arthroscopy, you can perform the following procedures. You can do synovial biopsy, which is quite important in these days to be able to know what's happening with the patient as far as whether they have primary arthritis or just a non-inflammatory disease entity. You certainly can lyse adhesions with double puncture arthroscopy. You can manipulate your disc for mobility. And most importantly, you can target the deposition of medications into select areas of the joint. And I'm talking about medications like hyaluronate, like Botox, like platelet-rich plasma, and maybe in the future stem cells for rejuvenation. So this is a very important component of arthroscopic surgery and joint treatment as we go forward. Next slide, please. Once you get into your second instrument, your second portal, then comes the hand instrumentation that you need to use. This hand instrumentation provided comes in this type of a container. This is the 2-0 system. Next slide, please. Within the 2-0 system is a component of hand instrumentation that I'll show you, both with probes and forceps, etc. And also within this system that I won't show you is a handpiece to hold a laser fiber so that you can actually move forward and do some ablations in the joint also. Next slide. Know the terminology. This is an operative system. This is your cannula. Note that the cannula has scoring marks on it for safety purposes and for vector measuring purposes. You never want to put anything in the joint and the fossa portal. So this will help you with your measurement. And then you have also a trocar and an obturator for insertion. Next slide. This is a straight probe. It's 1.8. It fits through the device channel cannula. It's the safest instrument that we can put into the joint. And remember, we're talking about patient safety here. This is your number one instrument. Next slide, please. You have a hooked probe. It's 1.8. It allows you to unravel adhesions. It allows you to palpate the texture of the fibrocartilage, determining what the consistency of it is as far as chondromalacia is concerned. You can also use it to hook the oblique protuberance when you're reducing discs. So there's many, many different things that you can do with a hooked probe. Next slide. We provided you with a series of forceps. You don't just have one forceps. They have different types of forceps that you can use depending on what you like as far as being able to procure tissue and to remove tissue in the joint. These are all in the size of 1.8, and they insert into the working cannula. The system is the water goes through the scope, it goes into the joint, it comes out the working cannula, you maintain your joint distension, and you can operate that way. Next slide. This is a scissors. A lot of us like to use a small scissors like this to cut an adhesive band. It's nice and neat, provides you that particular opportunity. And again, I'm showing you is these things that when you run into something in the joint, this will be available to you so you can actually execute the procedure as desired. Next slide, please. This is a bone curette. It's a little bit small, but it actually has it's a curette that you can scrape away diseased fibrocartilage and get down to bare bone on the fossa eminence complex when you're trying to increase joint space and trying to rejuvenate articular cartilage growth. You need to get down to bleeding bone and with some function afterwards to try to regenerate. It's called a bone curette. You also have, next slide please, you have bone files. So they're convex and concave bone files that you can smooth condylar surfaces, you can smooth the fossa eminence complex as the case goes on in more advanced procedures. Next slide, please. There's an irrigating needle provided here if you don't want to use the hospital irrigating needle, and there is some benefit to this irrigating needle because it's small, it's large enough to house a laser fiber. So when you get good, you can put this type of an irrigating needle in. If you're sort of stuck in the fossa, you can put the irrigating needle in and then put the laser fiber through it, and you can lase while holding the irrigating needle without having to insert it into a laser handpiece. It just gives you a little bit of extra flexibility as you go on. Next slide, please. This is a suction tip. When you put your scope into the joint, many times you'll have blood clot. You need to suck out the blood clot before you put your scope in so you can see well. And during the course of the procedure, clot may form. This suction tip fits down the small cannula system so you can evacuate clot and see inside the joint. Next slide. Okay, now level 3 arthroscopy. This is the advanced arthroscopy. And I definitely, we do this all the time. And there's docs in the audience that do the same. In level 3 arthroscopy, there's 3 procedures that you can do. You can do a discopexy. You can actually take the disc and put it back in position and you can do it all arthroscopically. And this is the way it's done. It's 2 puncture technique. And then once you get into the anterior component, your scope illuminates. You release the disc from the pterygoid muscle with a laser. You take your probe and you reduce the disc so it's back in the correct position. You take a suture through a needle and run it through the posterior band of the disc. You catch it. Both free ends now exit, and we bolster it now to a small button on the outside. It works very well. It's a nice procedure. It's a safe procedure. And it can be done arthroscopically repeatedly in Wilks 2 and Wilks 3 cases. In Wilks 4s, I question even disc repositioning surgeries in 4s and certainly maybe not 5s, but it gives you the ability to do discopexy. And then certainly you can clean the joint and you can take away portions of the disc utilizing this technology. Next slide, please. So what happens then when you want to get into larger arthroscopy, joints that have more stenosis, more problems, you can go to a larger system. This right here provides the ability to switch from the 2.0 system to the 3.0 system. It's a switch tick technique. that allows you to go from a small cannula to a larger cannula without trying to create another portal, so that you don't have to make another puncture in the joint. Now you have an empty hole and a lot of extravasation on the outside. You want to switch from a 2-0 to a 3-0, to debride more, to clean more, to use a larger probe, to open the joint more. This gives you the ability to do that. Next slide, please. And this is the outside portion of the 3-0 system. This is all available at the booth if you want to take a look at it. Next slide. And this is the inner component. It's the same equipment that you have on the 1.8. If you're so inclined that you want to do your arthroscopy with larger instrumentation, that's your call. I don't encourage it. I encourage you to use this when you get into advanced arthroscopy for debridement purposes. Next slide. Okay, so that's the equipment, and that's level 1, level 2, level 3 arthroscopy. We plan on training, and in Miami we'll be training over the next year. We plan on training 60 surgeons. Our methodology of training at the Mark Center will be as follows. The courses will be on a Monday. You'll come in on Sunday night. You'll be taught on Monday all day on this equipment, and then you'll be taught Tuesday. Tuesday afternoon, you can make your plane flight home. And depending on your level of sophistication, I definitely would expect you by the time you leave to be able to do level 2 arthroscopy. And hopefully some of you who have experience will be able to take it the next level to be able to do level 3 arthroscopy, where you can do advanced debridements and suture discopexy. I'm very appreciative of Nexus CMF providing this opportunity to oral and maxillofacial surgeons, giving us the abilities to have equipment on a consistent basis so that we can further the science and take care of our patients with minimally invasive surgery. I thank them very much for their efforts in helping us do this. And I thank you for attending, and enjoy the rest of the meeting. Dr. Keller.